How's it going, guys? We have a 28-year-old male who has serous pericarditis secondary to cocaine use. And it's a very buzzy descriptor, if you've been following my content, of patient who presents bent over at the waist, because isn't the pain with pericarditis worse when you lean back, better when you lean forward? So very buzzy how the patient can walk through the door. Following a night of heavy partying, they like that for cocaine as a cause of serious pericarditis. And then I explicate that the patient's not acutely intoxicated with cocaine. There's no tachycardia, there's no mydriasis, pupillary dilation, there's no confusion, incapacity. So ECG, you don't even need to answer the question here. It's obvious it's pericarditis, but you have diffuse ST segment elevation. It's what you need to memorize. Some students get obsessed about PR depression. That's fine, but it's the diffuse ST segment elevation I want you to know. That contrasts with myocardial infarction, where you get ST segment elevation in a few 3 to 4 contiguous leads, such as 2-3 AVF, but with pericarditis, they're everywhere. All right. So we're going to give 2 medications to manage pericarditis. Let's just hop through. Actually, before I even go to the answers, you should know that serous pericarditis, cocaine use, autoimmune diseases like SLE, RA, and viral infection. Doesn't have to be Coxsackie B. Those are 3 very important causes of serious pericarditis. And then fibrinous pericarditis, there's 2 types. There's post-MI, which can occur hours to days following an MI. They'll just say there's a friction rub. The second is Dressler syndrome, which is antibody-mediated, 2 to 6 weeks later, okay? USMLE actually doesn't give a fuck about serous versus fibrinous pericarditis. They're not going to ask you that, but I'm just telling you that those are etiologies of pericarditis that you have to know for USMLE. So how are we going to manage this patient's pericarditis post cocaine use where he's not intoxicated? Choice A, NF-kappa B, alpha-1 adrenergic receptor inhibition, wrong fucking answer. So it should be noted that if the patient is acutely intoxicated with cocaine, has tachycardia, has hypertension, we wouldn't want to give a beta blocker in isolation. We want to give an alpha-1 blocker like phentolamine, because cocaine inhibits the reuptake of catecholamines. So if you block beta receptors, you can get unopposed alpha, arteriolar vasoconstriction, you can worsen the blood pressure. If you're confused by all that stuff, go through my pharm modules on my website. NF-kappa B, there's a lot we can discuss, but it's a pass-fail step 1 now. But you should know that this is upregulated in inflammation, and that steroids will decrease NF-kappa B pathway. Okay, as I said, there's a lot we can discuss. There's a question on the NBME exam where you need to know NF-kappa B is in the cytosol, normally bound to I-kappa B. I-kappa B means inhibitor of NF-kappa B. And what they want you to know is the answer is, quote, I-kappa B releases NF-kappa B after undergoing phosphorylation. Okay, so steroids can help prevent the phosphorylation of I-kappa B. So NF-kappa B will stay sequestered in the cytosol, not go to the nucleus, and it won't upregulate inflammation. Point is, wrong fucking answer. Choice B, NF-kappa B tubulin for steroids and colchicine, wrong fucking answer. So point I can make is that colchicine, which can be used for acute pericarditis, microtubule inhibition, NBME can write the answer as tubulin. Holy shit. Not dramatic, but I mean, this does confuse a small percentage of students. They're like, oh, I didn't realize it referred to microtubules. Use your fucking head, okay? It says tubulin. So I've written in my PDFs, might confuse some students. I've talked about steroids can be used in the setting of acute pericarditis. So they say, what do you mean? How are steroids and colchicine wrong? It's because that pairing alone would not be what you give for acute pericarditis. You're not going to administer steroids and colchicine and that's it. Wrong fucking answer. Choice C, prostaglandin synthesis antioxidase, wrong fucking answer. So prostaglandin synthesis could be NSAIDs / aspirin. Xanthine oxidase would refer to allopurinol, febuxostat. It's not gout, okay? Now, it can confuse some of you because you say, wait a second, what about if he was binge drinking alcohol? Why do we have to assume it's cocaine? Well, binge drinking alcohol actually doesn't usually cause acute pericarditis, especially in young people. It tends to be middle-aged, 40s, 50s, some dude who just drinks alcohol, 3 beers a night over time, develops acute gout. Okay, maybe it's exacerbated by drinking, but it's not the typical demographic we're referring to here. This is cocaine, all right? And the other point is that even if you did think it's acute gout, We don't use xanthine oxidase inhibitors for acute gout. Allopurinol is used to decrease recurrences of gout. It's for chronic gout. You do not use allopurinol in the acute setting for gout. Choice C, wrong fucking is. Choice D, prostaglandin synthesis tubulin, correct answer. So you need to know that we give aspirin slash an NSAID such as ibuprofen plus colchicine. Those are the two drugs administered for acute gout, usually. Now, some students get very pedantic. You could be aware that if the pericarditis is associated with etiologies that could induce cardiovascular problems, such as cocaine or MI, that NSAIDs are typically, such as indomethacin, are typically contraindicated, that you'd prefer aspirin in those settings. NBME doesn't really go down that route. They're not going to put aspirin and indomethacin as two separate answers and force you to choose. They're not really it's not Qbank that way. You could be aware, though, that post-MI, pericarditis, cocaine, you would typically give aspirin plus colchicine. That's what you do, all right? If, let's say, you had a viral infection and you got pericarditis, or it's rheumatoid arthritis where you get pericarditis, you could give indomethacin plus colchicine, okay? So just, you're going to give a prostaglandin inhibitor, okay? This is what the NBME will do. So there's no ambiguity here. You give a prostaglandin inhibitor and you give colchicine. And then steroids are usually brought in third if these two don't work, or if the patient, or if the physician wants to add a third drug, okay? So let's just whip through the final answer choice here. Xanthine oxidase microtubules, wrong fucking answer. As I already harped on, you're not going to give allopurinol in the acute setting for gout, and let alone the fact that this isn't gout. And then microtubules, I just decide to be flagrant asshole and make it a spin, because tubulin and microtubules are the same thing, so maybe some students get confused here. Choice E, wrong fucking answer. You know the deal. Until you make more content, like myself, Scrunch. Appreciate your time. That's it.